Okay, well, good morning, everybody, or good afternoon in some cases. Welcome to the fifth webinar in our series on complex service delivery. It is actually the fifth. It was false advertising when we sent out the flyer. My fault, said the fourth. This is actually the fifth. I'd like to remind everyone that we're recording this video. Once it's been reviewed by our presenters, we'll post it on the web. My name is Alan Castle. I'll be facilitating the discussion today, and I'm joining you from the traditional unceded territories of the Esquimalt, Songhees, and Wasanich peoples. As our discussions unfold today, wherever you're joining from, I'd encourage all of us to reflect on how unspoken colonial assumptions affect not just the solutions we're considering, but also how we define the problems we're trying to solve in the first place. It's a healthy mental exercise to undertake, I think. This webinar series is sponsored by Connective, who, as most of you know, has just undergone a name change, formerly known as the John Howard Society Pacific. And I'd like to right now invite Mark Miller, the CEO of Connective, to say a few words of welcome. Mark.
Good morning, everyone. As Alan said, my name is Mark Miller. I'm the CEO with Connective. I'd like to begin by acknowledging that I'm speaking to you from the traditional and unceded territory of the Coast Salish people, specifically the Musqueam, Tsleil-Waututh, and Squamish First Nations. I'll try to keep my words of welcome short, as I know we're all looking forward to hearing our speakers today. But it has, however, been a very busy and exciting period of time for our agency. And I'm going to take a couple minutes of your time to talk about just who Connective is. Earlier this week, many of you would have received an email letting you know that we'd recently changed our name from JHS Pacific to Connective. As a result of our commitment to being adaptive, responsive, determined, inclusive, and person-centered, we've experienced both incredible growth and evolution as an organization over the years. As we continue to look to the future and all the ways we envision ourselves working towards our vision of safe, healthy, and inclusive communities for all, we realized that we needed to make a change in order to speak to who we are and what we do. So a bit about Connective. We believe that everyone deserves to feel safe and included in their chosen community. At Connective, we see a path forward for everyone with opportunities to learn, grow, and develop on their own terms and at their own pace. Connective is committed to facilitating transformative social change in communities across BC and the Yukon, and to reframing how society thinks about people facing systemic barriers. The Connective approach is person-centered, holistic, and community-based. Over the past 90 years, we've woven a strong social safety net that works to address the needs of everyone who walks through our doors. Our services include reintegration support, housing and homelessness prevention, employment outreach, community living, and other community-based services that create safe, healthy, and inclusive communities. In our continuum of support, people can find what they need to move forward and access assistance with navigating challenging social systems. In us, people find an advocate willing to work tirelessly to help them overcome barriers and achieve their goals. Connective is an agency that is constantly looking for ways to collaboratively work with our network of partners to ensure no one slips through the cracks. And finally, we believe our work in communities across BC and Yukon is a foundation to effect lasting social change for all of us. On behalf of Connective, I want to welcome everyone that has taken the time to join us for what continues to be critical discussions and learning opportunities. I want to sincerely thank our participants today. We greatly appreciate the time you're spending with us, and we feel very fortunate to have you share your knowledge and experience with us. I want to thank our staff and Alan Castle for their work on this initiative, and again, thank our advisory committee for their continued work and time. And I'll turn it back over to Alan. Thank you.
And myself, facilitator's first tool there. Thanks very much, Mark. And so our previous discussions in this series have focused on all around a theme, but slightly differently. First of all, on the general theme of complex service delivery and the path to holistic person-centered service, like what that actually means. Secondly, we also spent some time looking at the reality of seeking services from the perspective of those with lived experience in BC in a couple of different sessions. And we also have looked at issues around substance use, service delivery, and service eligibility and how those interact. And at our last meeting before the summer break, we sharpened our focus on the whole question of person-centered service and began to look at how do we, practically speaking, bridge different mandates, different structures within the health, justice, and social sectors to try and place the persons, the clients, but the persons, fundamentally, holistic needs and outcomes in focus. And in the first of those discussion, well, in the first of this particular subset where we're looking at how you do this practically, we looked at some international examples from overseas, from Australia, from the United Kingdom, but this time we're looking closer to home, and we're very fortunate, first of all, to have a presentation from the Massachusetts Community Justice Project. The Massachusetts Community Justice Project brings together local criminal justice, treatment, recovery, crisis, healthcare, and social service providers to identify local resources and gaps in services and create an action plan to enhance collaboration around client service and to reduce the risk of justice involvement and recidivism for those with addiction and or mental illness. Presenting on that, we're fortunate to have Marisa Hebel from the Executive Office of the Trial Court of Massachusetts, who's the manager of the project, and she's joined by Dr. Jenna Savage, the Deputy Director of the Office of Research and Development for the Boston Police Department. We're also fortunate to have some local experts involved as well today. Regular viewers, if I can use that term, will be well acquainted with Johnny Morris, the CEO of the Canadian Mental Health Association's BC division, who's facilitated some of our webinars. Because he's presenting today, he's not facilitating, so I guess everyone else's loss is my gain there. He is joined by Amelia Moretti, who is the policy director for CMHA BC. And Amelia and Johnny are going to be discussing the peer-assisted crisis team, or PACT program, which has been developed as an auxiliary or alternative to police response to people in mental health crisis in the community. What we'll do is we'll have the presentations first, beginning with our guests from Massachusetts. And when both presentations are complete, we'll move to questions. So a few housekeeping things here before we move on. First of all, please try and have your camera off and muted unless you're asking a question. And there are two ways to ask a question when we get to that point. One is you can use the reactions tab on Zoom to raise your hand, or if you don't feel you want to ask your question live, you want to just put it in the chat, or you can just send it directly to me and I can ask it for you. So one of two different ways. And then towards the end of the discussion, I'll give our presenters a final chance to offer some concluding thoughts. So that's it for me for now. And now I'd like to turn the floor over to Marisa and Jenna for their presentation.
Thank you, Alan. This is really exciting. I'm happy to be here and have my close colleague Jenna Savage with me, as well as Tess Jurgensen. I will say that I'm so happy to be presenting to you, but just everything I've heard so far tells me that we have equal parts to learn from you guys, because it sounds like the work that's happening here is pretty remarkable and obviously right up our alley. So let me just get our PowerPoint started here. Can everybody see that? Jenna, I can see you, so I can't see anybody else. Okay, cool. All right, so what we're gonna do is I'm gonna talk relatively quickly. You're gonna be able to tell that I'm originally from New Jersey, about just what our project is, the Massachusetts Community Justice Project. And then Jenna's gonna talk about, we're gonna talk a little about the work that's in Boston, and really like this one specific, one initiative that particularly Boston Police Department, has really taken and run with in a way that we really hope to see in communities, just in a really impressive and important way. So I know that everybody here clearly already knows this, but I'm going to say it anyway, just to set the stage. Oh, I didn't mention that I am a public health professional and I work in the Executive Office of the Trial Court in Massachusetts. And I always point that out just because I think it's pretty unique. Unfortunately, I hope it's not always unique. But I think it's important to have those boundary spanners, who really understand different systems. So we know that we are working with people who have complicated needs. They are dealing with mental health issues, substance use disorder, oftentimes complex medical needs, involvement with the child welfare system, housing and homelessness, houselessness, and intersection with the justice system. So, which is complicated already, but then we also know that these issues are sitting in the social determinants of health, like poverty, stigma, racism, transportation deserts. So this is no small task in front of us to really address this work. We know it's complex, it's complicated, and it takes a lot of collaborative work, which is really what everything that we're designed to do, is to reach across sectors to really build those bridges, those sustainable bridges. So the Massachusetts Community Justice Project is a statewide sequential intercept mapping project, which I'll talk more about. Sequential intercept mapping is like our core tool. And really what we are working to do in community, but also at the state level, is to bridge those connections in between systems. Because we know that people are, like I said, intersecting with all of these multiple systems, and they're very siloed. We know that even within our systems, we're siloed. We've been doing this work for a long time. We remain siloed, although it's getting better. It is definitely getting better. So we use the sequential intercept model, which I will talk more about, to really look at what do communities have, what do they need, and how do we really build that capacity for communities to identify what is most important and to get that going. We do, I think there are a lot in the United States, I think there are a fair amount of sequential intercept mapping projects. I think we are the only one that is led by the court. Which is unique, has its own pros and cons, but one pro I will definitely say is that the judge, the ability of the judge to get the right players to the table is really significant, and we milk that as much as possible, just because it's like half the battle to get all the right parties to the table. So we are in the trial court. I'm in the trial court. Jenna works for the Boston Police Department. And we conduct one of our core strategies is the sequential intercept mapping. And we conduct these 2-day workshops that are made up of sequential intercept mapping and taking action for change, which is really action planning. And like I mentioned, judicial leadership and involvement is really key. And it has been particularly significant in Boston, I will say, with this one real powerhouse judge. Lots of powerhouse judges, but one real powerhouse. So some of you may have heard of the sequential intercept model. I'm not sure how much this has been done in Canada, so I'd love to hear. For anybody who has not heard about it, it is a very, despite the name sounding very complicated, it's a very simple concept. It really just lines up the criminal justice system into a series of touch points, a series of stages. We know that people move through the criminal system in a pretty predictable flow. And so the model actually enables us to look at every stage of the justice system and say, okay, when it comes to people dealing with mental illness or addiction or both, who are at risk of involvement with the system or are already involved, what do we have and what do we not have? Where do people go? What happens when they go there? What questions are asked? Is there a validated screen that's asked? And it really helps communities organize a targeted strategies around plugging the gaps that we identify through this process, which I'll take us into a little bit more. We also talk a lot about the community intercepts, and the ones that are at the baseline are just in pink because this is a court-led project, and there are some things that we can be doing in the court, especially on the civil side, that we would also hope are early interventions. All of the research plays out, I'm sure this won't surprise anybody in this room, that the more top-heavy communities are, the more that we can make those systems more person-centered, more coordinated at the front end, the better the outcomes are for everyone, particularly the individual, but also communities. So the way we actually use this model as the framework pretty much for all of our work. But one way to bring this model to a community, and the way that we've worked on it in Boston, is to bring together all of the partners, ideally all the key partners. As a public health person, we're usually bringing together like everybody, as many people as possible. This is actually a little different. We bring together all of the key stakeholders. We shoot for like 40 or 50. That never really happens in Boston because there are so many key players. Across systems, people who are not usually in the room together, to do a few things. So the group actually creates a map of where people actually move. What happens when people are in crisis? What number is called? They create a map together collectively, this group of 40 or 50 key stakeholders. And during that process, we find, not surprisingly, that there are a lot of resources in the community. And also that there are gaps. And I mean gaps not only in programs, which we often have, but especially in a community like Boston that is actually pretty resource rich. But where are we disconnected? Like how are we exchanging information? How do we actually really keep that person-centered continuity of care from start to finish? And this is complex, right? So we create this map. We create this giant list of resources and this giant list of gaps. I'm going to actually talk to you a little bit more about how we create that. And then we actually start to action plan. We say, okay, we create this giant list of gaps. The group agrees on what is the most important for this community, going with capitalizing on the resources that we have. What are the gaps that we can do the quickest with the least amount of resources? And then what are the ones that are really the most significant? Hopefully they're the same, but usually they're not, because we know these are complicated problems. So just to pause 1 second to say that this is just a sample of some of the things that we use in some of the questions that we use in creating that map. So not only are we actually talking physically about where people are moving and what happens there, particularly when it comes to like validated screening and assessment, connections to care, education, but we're also asking about what we know are the best practices, as well as innovations that are often coming up. Like, for example, in Massachusetts, given the overdose crisis, innovations like post-overdose response has come up. So we'll talk about those too. When it may not, maybe it has some research behind it, but we talk about the evidence-based and best practices, as well as understanding if there are some innovations happening. So this is just a sprinkling of what we ask, just all the way through. From every stage, really, in the community, and also from crisis, pre-crisis, and all the way through the justice system, as well as what do we want to see in a robust way in communities, like how are communities working on these issues. I always say that sequential intercept mapping workshops are only as effective as whatever happens after, because they are needs assessments. They are like capacity building, collaborative needs assessments, but the real work happens after, which is why I brought Jenna along to really talk about the real work. So there's multiple stages. I've actually talked a little bit about this. We plan, we pull a group together, and I'll talk a little bit how we did it in Boston. And we implement these workshops. And then, like I said, there's this follow-up and what do? We really try in the planning process to make sure that we are working with the partners on the ground. Actually, we try to make sure we're working with the partners on the ground all the way through, because that's who's going to really hold this work. Because this work takes a long time. Some things we manage to get accomplished in relatively short order, even just from bringing all these partners together, the amount of clarity and awareness that happens when law enforcement can hear from the director of the emergency department, the medical director, why people are leaving right away, like what the medical director's charge is and what their barriers are. I mean, there's some really amazing stuff that happens in the moment, but a lot of this work is systems level work that needs funding and resources and coordination. It takes time and leadership, which we have in Jenna Savage and First Justice Kathy Coffey, who really did say at the beginning of this project, we're going to do this in Boston. We're just going to do it. We're just going to jump in. And she brought together a cross-sector group of the Boston Police, the district attorney's office, the public defender's office, our crisis clinicians, which is called the best team in Boston, and a homeless shelter, which kicked off a series of 6 of these workshops that we did throughout. We mostly organized them by sort of regions of how the courts are organized. There's one area that's extremely complex, that's dealing with a lot of complex issues that we've targeted. And then the last one that we did actually was citywide. And I'll talk a little bit about how this work keeps going. I hope I have enough time for Jenna to talk, because I only started, are we 10 minutes in? Okay, I'm gonna speed through the rest of it. Okay, so this is just an example. We also can send all these slides out. This is just an example of of what a sequential intercept map looks like. I don't expect everybody to see this, but just an example. We created one of these at every workshop. At every workshop, the group, like I said, agreed on the top priorities, what they thought was the most important for that portion of the city, if not the entire city. The group created a steering committee. There wasn't a group that was working across sectors, meeting on the regular to discuss these issues. They created a steering committee and chaired by Jenna in conjunction with a prosecutor who was in the district attorney's office, and now she teaches prosecutors how to be prosecutors. And then subcommittees formed around the priorities from the first workshop. And we're particularly going to talk about how co-response, Jen's going to talk really about how co-response has been a major priority and how that work has been shaped. So this is just to show that a lot of pieces related to first responders and co-response amongst every workshop, there was discussion about this. That committee meets on a monthly basis, has been a really close collaboration between the Boston Police Department, the clinicians, and Boston EMS, and has other partners who knew that it was going to be critical to be involved in this work. Okay, so now I'm actually going to hand the baton over to Jenna, who's going to talk. I also just want to say one thing is that the Boston Police Department is doing a lot. I pulled out 4 examples of what they're doing. I just don't want it to be implied from this slide that they're only doing 4 things. They're doing a million things. I'm going to pass it off to Jenna now, and then we'll circle back.
You are hilarious. And thankfully, we both talk really fast. And neither of us is bringing the Boston accent to the table. So I apologize if everyone's going to be disappointed because it's just not present. Hi, Jenna here. So yes, as Marisa pointed out, the BPD has been doing a lot of great work with respect to mental health and substance abuse. We had been working on co-response, where we have mental health clinicians co-responding to mental health related calls for service with police officers. Since 2010, we've been doing this, and this is kind of what just highlights the importance of this sequential intercept mapping process, is that we were doing this for 10 years, but it wasn't until we did our mapping that it became very evident that at every mapping we did, and Boston is just so complicated that I'm sure a lot of other towns and cities just have one mapping for their city. We've done 6 and we still haven't gotten to everything we need to do because there's just so much variation across the city of Boston, by the Boston Municipal Courts districts, by police districts, by WIP. We're going to do a whole separate one for juveniles. It's complicated, but we've been doing this work with co-response for 10 years. But what we found is every time we did one of these 6 mappings, more co-responders kept coming up as a priority of a thing that we needed. Because at the time we only had at most ever 3, usually just really 1 or 2 consistently over the years. And this data that Marisa has up here just shows, so I know this is a universal issue, tracking the number of mental health related calls for service is essentially impossible for us here in Boston. We have one nature code called EDP, which is emotionally disturbed person. And it comes in 2 type codes. EDP2s are those calls where both police and EMS respond because there's some level of risk to harm, self or others, some weapon present, something dangerous. EDP3s are lower level calls where there is no risk. And so EMS can go alone to those. So as you can see, this was 2019, so we didn't really have a chance to get more up-to-date data, but we're getting at least 10,000 calls a year that are explicitly mental health, which means there are thousands and thousands of other ones, which could be domestic violence, fight, pretty much you name it. More calls than not, I truly think, have a mental health component to them. So this is really just an undercount. But so we were doing co-response for almost, since 2010, but it wasn't until it was brought up as a consistent issue that we actually formed a subcommittee. So a subcommittee was made for each of the priorities that were identified in these mappings, with one steering committee to rule them all. I guess move forward to the next slide. Let's see what it says. Okay. So traditionally, before the BPD partnered with BEST, so BEST being the Boston Emergency Services Team, which is our mental health partner, those are the clinicians who ride with our officers. Before that, we pretty much had 3 options. One was, just send the person to the hospital with EMS, take them to the emergency department. One was just leaving the person on scene with no services, or arresting them. Those were pretty much those were the officers' options before this co-response model went into effect. Okay, next slide. So Boston Emergency Services Team, they are our local emergency services provider. So they are mobile clinicians. Their bread and butter is that they have mobile clinicians who work 24/7 that can just go to calls for service. They have a 1-800 number that is 24/7. So this is what they do. They are mobile clinicians, but they, in their regular line of work, don't have lights and sirens. They have these clinicians in their own cars getting there. It on average takes about an hour to get there. They also have to take, I always forget if they're not insurance blind. So they have to I think they can either only assist people who don't have insurance. I think that's the way it is. So, they are a huge resource in the city of Boston that we need to get the word out about more, but there are limitations in terms of timing and in terms of who they can assist. But they are an incredible resource. They also have urgent care centers, and they are master's level mental health clinicians. Next slide. So as I mentioned, the partnership started in 2010, and please just cut me off if I run out of time. Technically in 2008, there were only 2 officers who were working with BEST originally. There were our 2 street outreach team officers who focused solely on homelessness. But then we expanded that partnership so that we could make BEST more of a resource to all of our officers. And this all started with grant funding. So BEST literally walked in the door of my office and said, we want to apply for a grant where truthfully all the money is going to go to us. But if you do the application in 4 minutes, thank you. If you do the application, we'll make it worth your while. And we've been working with them really hardcore since then. And so we created a mandatory online e-learning video for all of our officers to learn who they are. And we use initially state and then later federal grant funds to fund these clinicians who would be specifically dedicated to riding along with officers. So that was all grant funded. And then in 2017, an incident took place in Boston that kind of brought mental health to more of a public attention. And we were able to get operating budget funds to continue to support our clinicians because grants expire and we were losing personnel and it was hard to find people to be grant funded. And in 2020, lots of changes in the political atmosphere. We ended up getting funds to hire 15 additional clinicians. Next slide. This is just a little flow chart to show you how it works. But in general, the clinician rides along with an officer. They can either be dispatched by operations by our 911 call center, or they're just the whole time listening to the radio. And they might organically hear a call that like, oh, we know that address, we're going to go there, we know that person. Or and so they'll get there. The clinician adds a lot of tools to the officer's tool belt. They can assist with involuntary psych evaluations called here. They're called section 12s here. They really do help with diverting from arrest, diverting from emergency departments when not necessary. Yep, you're moving me along. I like it. BEST helps officers, again, by giving them more tools in their tool belt, also helping with holding cell evaluations. They also help just one-on-one training. They're constantly training our officers and forming really great relationships. And then simultaneously, the officers are helping BEST, next slide, because as I mentioned earlier, they can't get to things in a very timely fashion on their own. So now they've got lights and sirens, they're getting there faster. The agreement they have with us is that they will be insurance blind. So if a referral comes in through BPD, it does not matter if the person has insurance or not. So now BEST is getting access to all these people that they may not have been able to help before. And let's see, yep, keep going, I'm just gonna keep going. Among the outcomes. So yes, just some data, you know, we kind of know a lot of these calls are just, they're not criminal. So only about 30% of the cases in FY20 actually had any kind of criminal behavior involved. And of those 192, only about a quarter were actually charged, often with a summons, which is less disruptive and traumatic than arresting someone on the spot. That's when they could get called to court later. But we know we're also just, even the most hardcore traditional of officers have accepted co-response among the BPD, and it has become institutionalized in this really amazing way that there's just more and more demand for clinicians, and we're changing every day how we're doing it. We're improving things and really just institutionalizing this practice, which is incredible. What does the other side of the slide say? Can't wait to see. Yes, okay. So other things, BEST has also become, we are, I'm sure you've all heard of CIT, which is Crisis Intervention Team Training. We're now going to be having our own out of the BPD Academy, and BEST is a huge partner with us in helping us teach our officers, both incoming officers who are new recruits and in service training. They're helping us develop a new CIT training curriculum. We have hub tables. I think you guys should all probably know what hub is, because I think it started in Canada, or at least came from Canada before us. But we're just doing a lot of new steps, and BEST, our mental health partner, is key a part of that. And these, I didn't even talk about the co-response subcommittee, but these, basically we're meeting monthly to really talk about the stuff on the ground. That's the important thing. Like these meetings, we are able to bring these partners together, that even when there's political stuff up top making things difficult, at our meetings, the people who know the most and care the most are at the table and able to discuss things in real time about like where there might be just miscommunications, things get handled and smoothed out and protocols get changed, just very in real time. Really amazing watching these partnerships solidify. And we've been meeting monthly since 2017. Is that it? Yeah, that's it.
Okay. Well, Janet, that was, and Marissa, thank you very much. That was a wealth of information but well presented, and all kinds of thoughts and questions bubbling up in our minds. But we're going to have to hold off on those because we're going to move to another presentation. But I would encourage everybody, if you've got some questions based on that, just you can send them to me or put them in the chat just as we go. And I've already got a couple compiled here that have been sent to me. So Johnny and Amelia will now move to you. And I don't know if you guys have figured out a sequence. Amelia intimated that you had, so I'll leave it to you.
Great, thank you so much, Alan. And it was great to hear the presentation there from Boston with Marissa and Jenna. It was a great overview, and there's so much in the material that was just shared that has a linkage to the work that Amelia and I are going to catch you up about. So for the time we have, and some of you on the line are quite familiar with this work, so we'll drill into some more detail, and for some of you it might be new. We're going to catch you up between ourselves on the concept of community-led mobile crisis teams, and you'll see the tracing and the alignment with many of the ideas that we've just heard from the Boston team. So first, I do want to acknowledge this morning I am joining you from unceded and ancestral Lekwungen speaking territories, known today as the Esquimalt and Songhees and WSÁNEĆ territories nations. And very privileged to be joining you from these lands. We're going to walk through some strategic policy context here with regard to the role of peer-assisted, civilian-led crisis teams and our work with partners, including the provincial government and others, in trying to realize that concept here. Amelia is going to put a finer point on the concept that we are trialing in a number of communities, and also shed some light on the community design process that has some alliances with the material that we've just heard about. So I think many of you have seen me here at these fantastic webinars that Connective and Alan have co-hosted with other partners around the advisory table, and these have been such a fantastic opportunity for knowledge exchange and sharing. For those of you who might not know me or much about CMHA, I have the honor of working as the CEO here, and we've been around in Canada for about 103 years. So we're a settler organization in this country, and we've been in and around here in BC since '52. We're a federation, and from our roots here, at least in the BC office, we've had a long history of doing systems level advocacy and influencing around changes, particularly the interface point between folks living with mental illness or substance use problems, experiencing crisis and distress, and the complex and arguably disproportionate interface with the justice system. And so there are 3 reports that you can see on your screen here. Knowing some of you are in the public service, you'll likely be quite familiar with the one on the right. But the one on the left was written about 20 years ago, and that's the study in blue and gray. And it's well worth picking up and reading again, because so many of the recommendations that are included in the study in blue and gray show up in the work that is still required today when we think about this important concept of diversion, and still hold true. There's definitely been some progress against the recommendations in that report. And whether it be the sequential intercept model, or whether it be thinking about community planning and situation tables, much of that thinking was happening a couple of decades ago, and it's fantastic to see it starting to come to fruition here, particularly when you read minister mandate letters where situation tables and reducing reliance upon police are in, at least here in the BC context, showing up in multiple ministers' mandate letters going forward for this current term. And then on the right, the middle one was a follow-up to that study in blue and gray, and on the right is some work that we ghost wrote alongside colleagues in the government here around a state of the union when it comes to interfaces between mental health and substance use services and police here in BC. And it's a toolkit that explains whether you're municipal, RCMP, or within Indigenous policing, some of the current state of work that's happening at these complex and multi-point interfaces, whether it be the Mental Health Act, the criminal justice system, courts, remand, corrections, and health going forward. So well worth a look. So with a couple of slides I have left here, what we're up to here in BC. And so we've got some very early developing work on the mainland in a couple of communities, North Shore, Vancouver being one of them. So the District of North Vancouver, City of North Vancouver, and the District of West Vancouver. Some work developing in the City of Victoria, and as of recently this week, council level support at the City of New Westminster. What we're contemplating with some of these early trials and pilots is tackling crisis in a particular kind of way. Currently, we have ranges of crisis that are at play in communities, and on the left, of course, you see crises that might involve safety risks or threats of harm to self or others. In the middle of a body or a range of health risks, like an active attempt related to suicide, psychosis, overdose, etc. And on the right, a range of crisis drivers that can absolutely lead to a distress or a crisis situation. So housing insecurity, housing precarity, loss of housing, loss of employment, conflict at home, depression, anxiety. And we are firmly of the view, and I think our colleagues who just presented before us are, and likely many of you listening in, that there is an opportunity and an imperative to enhance what can be done in communities around both responding in the immediacy to these kinds of crisis drivers, and also the connecting, the warm handoff, the follow-up, the integration, all of those words that we use around trying to bring care around the whole person. And we're of the view that we have an opportunity with our partners, which includes the province, health systems like Island Health, police forces like Victoria Police Department or New West Police Department, first responders and community agencies and people with lived experience to do something in an expansive way around those crisis drivers on the right-hand side. So here in BC, and we've recently testified to the special committee that's looking to reform the Police Act. You've heard me provide comment on that previously. We do have a structural system that creates particular kinds of conveyor belts, and that's my language, when it comes to the fact that here in BC, the coroner's service in a death panel review report a number of years ago did describe the police service as a default mental health responder. We've arrived at this by no accident. I mean, we have arrived at this because of legislative requirements. We have a piece of legislation here in BC called the Mental Health Act that it statutes the responsibility of police officers in apprehension, conveyance, recall of folks who meet particular kinds of criteria. And in government's reform of the Police Act, we've encouraged government to also take a look at the Mental Health Act, because they are symbiotic in the manifestation of police being a responder on the front line for so many mental health emergencies. There's also arguably such an opportunity to strengthen the navigation, connectivity, and availability of community-based resources and their interface with the health system when it comes to crisis care. And ultimately here, what unfortunately happens, and of course, if you were to apply a geographical lens, some communities, the only response service that is available might be a police detachment, like an RCMP detachment. Currently, there are a couple of poles in the continuum that are typically used in responding to crisis. We, of course, want to see zero use of police cells or incarceration systems for people in distress and crisis. And we recognize that at times that's what happens. And also the emergency department is a response where people are taken when they are in crisis. We would argue that whilst particularly in the emergency department, care can be provided, care is provided, there are other opportunities, and there are at play, which I'll get into in a second. So this here in BC is our kind of on a PowerPoint back of an envelope slide deck, a bit of an articulation of the crisis response continuum in BC. And this does not represent every single community, nor is it geographically available throughout this vast province. But on the left, of course, there's RCMP, municipal, Indigenous police responses, the presence of mental health liaison officers. We heard a little bit of this detail with the Boston presentation. This co-response stream, which was a huge theme in what we've just heard. In BC, we have a number of communities served by CAR 87s, CAR 88s, CAR 67s. Here in Victoria, and I'm seeing at least one person on the line today who knows IMCERT very, very well, the integrated mobile crisis response team, a real innovation here on the island in and around the provisioning of plainclothes police officers, highly trained alongside child and youth and adult mental health service providers, responding at set hours throughout the day in a co-response model, and it used to be called CMHA. Underneath that, other kinds of crisis pathways here, at least on the island, and I know this does exist in some form elsewhere in the province. The role of the ambulance service, which I think there's some important dialogue that can be had in BC around ambulances. They're often deployed, of course, in significant ways to respond to the drug poisoning crisis and the toll that that's taking here. And where we're trying to kind of position what we're creating here under the banner of PACT, or peer-assisted crisis teams, or civilian-led crisis teams, are teams that are staffed by peers and mental health specialists. And Amelia is going to provide some nuance there in just a moment. So again, just some detail here. I won't go through all of this text. It'll be available in the slides, but it gives you some additional composition of kind of post-crisis care responses too here in the province, including we have an array of and it's not on this slide actually, ICM teams or integrated case management teams, assertive outreach teams, assertive community treatment teams, COAST teams or community outreach teams. Again, we're again looking at adding this component at the end on the right-hand side there, which Amelia will address in a second. I'll close out my comments here before handing the baton to Amelia to say there is such an opportunity here in BC with some of the operationalization of what we're doing to also take a close look, and we're so impressed with what's happening in Massachusetts there around joining things up. Is there a conversation for crisis care reform that could take place in BC that stitches and integrates and ties all of these responses together and avoids it being a postcode lottery depending on where you live? What's the minimum level of coordinated crisis care that we can provide in communities if you don't have the teams that are sitting in front of you on the screen? And one very active thread for us is we can build out this team that Amelia is going to explain to you in a second. But with those two poles, arguably the emergency department being a dominant pole or receiving area for people in crisis, what else is required? And so it's fascinating to hear our Massachusetts colleagues describe crisis care stabilization receiving centers, which are starting to proliferate in Australia. And in the UK, we've got some meetings upcoming with the province to explore what that could look like here in BC. But there is such an opportunity, and I'm so proud of the partnerships that folks are leaning into, whether it's New West Municipal Council, Island Health, Victoria Police Department, the RCMP, community agencies, community serving agencies, and people with lived experience in designing something here that's got some precedence in this country and in the US, but definitely some new ground to chart here across British Columbia. Amelia, over to you.
Thanks, Johnny. And I just had my eye on the time, so I know we're running a little late, so I'll probably keep my remarks fairly brief and just move through it fairly quickly. As Johnny mentioned, the peer-assisted crisis team is an alternative auxiliary service to police response to crisis calls related to mental health. And the idea is really to focus on those crisis drivers that Johnny mentioned. Is what we're seeing in the pathway from the crisis moment into our systems of care is that often people are ending up in police cells or emergency rooms that are assessing for safety risks and risk to life. And often crisis is a result of life circumstances that compound and lead to high levels of distress. So the peer assisted care team is a service that can address those layers of crisis, whether that be housing, food insecurity, family conflict, depression and anxiety, and keep people connected to their communities. The teams themselves are structured a little bit differently than a co-response model in that there's no police officers present. So we have paired a mental health professional with a trained peer crisis responder. The mental health professional is a pretty broad category, so it can be a social worker, a clinical counselor, somebody with community support worker training, and then the trained peer crisis responder is somebody with lived and living experience of mental illness, substance use, and experiences with the criminal justice system. And the idea of pairing those two professionals together is that you're able to provide that shared experience as well as the kind of clinical expertise and ability to provide on-the-spot mental health assessments. And really when we frame up what the response is, we focus on the relationship. So throughout our community consultations, we heard repeatedly that what people needed was someone to talk to, somebody who could listen and really understand, and somebody who would walk alongside them to access necessary health and social services. And so that's really the role of the team: immediate de-escalation and then navigation and referral. And so how do we build this? So there's multiple steps, and on the topic of today's webinar, it involves many different key stakeholders coming together. And it also looks a little bit different in different municipalities depending on what the needs of the community are. And so our first step across all 3 municipalities was to convene a systems planning table. So this included local police departments, city staff, health authority staff, local Indigenous leaders, other community partners, to really address the systems integration piece, such as 911 dispatch, intake assessment, triage, information sharing, all of those core structural pieces that are important for integration. The next piece is getting into community and identifying who are the key community agencies that are serving the individuals who will be accessing this team, and connecting with them to understand what the gaps are within the system, and then connecting with the people whom they serve to understand what their experience has been accessing our crisis care system, and what their needs are, and how they're either being met or not being met by the current service provision structure. After we've gathered all of that knowledge, we kind of select key stakeholders who identify an interest in continuing their work and contributions to build a community design table. And so this is predominantly people with lived and living experience and their family members sitting alongside trusted service providers to identify what the team needs to look like. And this is all of the key operational components around staffing, hours of operation, training, everything that goes into consideration for the person who will be receiving the service. And so this is the model that we've been using in 2 municipalities, the city of Victoria and soon in the city of New Westminster. It differs a little bit from what we've done on the North Shore. And one of the differences is that on the North Shore, we combine the systems design table with this community design table because there was the trust and safety within that small community for people with lived and living experience to sit alongside police. We heard in Victoria, as well as in New Westminster, that there needs to be a little bit of separation in order for the voices of people with lived and lived experience to be centered and for there to be trust among key stakeholders. And the role of CMHA in that process is the convener and also the person who maintains accountability and streams of communication between those 2 tables to ensure the needs of people with lived and living experience are reflected in the model that is fully, adequately integrated within the system. And so from there, we co-develop the model. So we take what we hear at the community design table, we link it to what is being organized at the systems level table, and we pull it all into a program model that is then put forward to the city in the 2 cases of the City of Victoria and the City of New Westminster, or to the community agency as it is on the North Shore in order to move towards implementation. And implementation is the last piece. So for New Westminster and for the City of Victoria, there's a procurement process. It's really important that we identify a community agency that's trusted, that's already serving the population that will be accessing the service. So that we do that through a request for proposal or an RFP process. And a subcommittee is formed that combines the systems planning table and the community design table in order to assess proposals and select operator. And then from there, we pilot the service and evaluate to see if it's effective in improving health and social outcomes for the individuals. And then we also evaluate for systems outcomes. So we're looking to see that there's a reduction in emergency department usage for minor mental health concerns. There's a reduction in Section 28 apprehensions under the Mental Health Act, and that people are staying connected to community services. I'll pass it back to you, Johnny.
Thanks so much, Amelia. And I'll just quickly say before handing things back to Alan, already just hearing the Massachusetts example and our familiarity with the sequential intercept model, it readies itself as such a good tool. Amelia and I were backing and forthing on, could that be a neat tool to overlay with some of our community design and community planning processes? So already we've got a good kernel there to take away. But thanks so much for listening to our presentation, and big thanks to all of our supporters, including the province, who've provided funding for partially implementing the North Shore team and also on the Victoria side there as well. So back to you, Alan Castle.
Thanks very much, Johnny. Sorry, I just need to get my gallery up here so I can see folks. There we are. two excellent presentations and so many common threads. And as I'll mention that, as they say on the radio, our lines are open. The chat line is open for questions, but I've got a few here already. So if you're still formulating your thoughts, just pop them in the chat when you're ready. I thought I'd start with Marisa. I'm fascinated by the role of the court here, Marisa, because courts across North America tend to define the scope of their potential interactions with the community very idiosyncratically. There's not a lot of consistency. So I'm interested to know more about the role of the judiciary specifically in this, and about the convening power of the court and how important that has been to make this happen. Could you reflect on that a little bit, if you don't mind?
Yeah, I will say that I don't know that it's been comfortable for everybody, because for very specific reasons, judges have been trained to, of course, be neutral and to not influence what's happening in the community. And so I will just say to start, there was a lot of discomfort, about, ooh, what does this mean? We're going to have judges in the room with law enforcement, with with hospitals, and particularly on the law enforcement front. What does that mean? How are judges going to be participating? We don't want judges to influence anything. And then, we had a lot, but at the same time, while there was discomfort and growth that was happening, there were also a lot of judges that were already listening. All of our judges are listening, of course, but they were also listening and talking and communicating. And frankly, it took a lot of judges, and particularly Judge Kathy Coffey in Boston, who already could see the benefit. She was a specialty court judge. She was a homeless court judge. She had a mental health court. She could already see how much it was impacting the clients that were moving through the court to have these partnerships with Boston Police Department, with the clinicians, with peers in the court. I actually didn't mention some of the pieces around peers, but it's really taken that, and it's actually been changing, I would say, in my perspective, in the last 6 years of working directly for the court, even though I was working with courts before. It has really shifted, I think, what not just sequential intercept mapping, but that whole approach that judges can be in the community and listen and can hear and can frankly educate people about what the courts can and can't do. The courts still feel very confusing to people, which I don't blame them, at least in the United States. I still hear people say, the court is a black box. I don't understand how things happen. And I don't blame them, because it's complicated, but I think it has to have judges really out in the community. And we also, in Massachusetts, I think it's definitely different in other states, but in Massachusetts, our judges are not elected. They're appointed for life. And so maybe in other states that if they're elected, they're out in the community more because of that, because they're campaigning. Ours are not. They're actually not supposed to play any kind of political role. So I don't know if I answered your original question. I think it has shifted. I think, and actually, there's really this common theme that judges, not only can judges convene the right players, but they should. They should. They just are in this position that they can convene the conversations. Should they be dictating what happens? No, and we're really careful with sequential intercept mapping to make sure that the community partners are deciding, what happens, what after that, and that the judge is not dictating anything. But and it's a balance, but judges know, they know what their role is. And I think it's important. It's been a shift for sure in judges having a role like this.
Thank you. And then just to follow up, so the level of court, so here in this province, we have two different levels of court. We have provincial court, which handles most of the garden variety criminal activity. We've got a Supreme Court, which handles another sort of subset of rather more complex trials, and then an appeal court. So the court that you work for, which is equivalent to which of those would you say?
So I work for the entire court system. I work for the Chief Justice of the whole court system, except the appeals court has its own little separate thing, and our Supreme Judicial Court has its own, but they're all connected. We have 7 court departments that fall under it. So I do most of my work with what's called district court, which sounds like it's more like your provincial courts. It's more where it's our conveyor belt, unfortunately, of people dealing with addiction and mental health issues. That's where all the low level, that's where all people are processed through that court in the first place. So that we actually decided to start there because that's where there's frankly the most need and the least amount of coordination from our perspectives. Our juvenile courts, could be a case made for getting in early and intervening, but our juvenile courts actually have a lot of off ramps built in. importantly, built into the system in ways that our adult district courts, that conveyor belt didn't. So it's actually where we really opted to get started. And I would love to say we're going to work ourselves out of a job, but it's complex, it's complicated. There's still a lot of work for us to do.
And Marisa, all of that is within Massachusetts though, right? When you say like the whole court system, you just mean the state of Massachusetts.
Sorry, yes, just state of Massachusetts. Yep, exactly. Yeah.
Thank you. I want to get to some questions for our BSU folks as well, but I just did want to follow up another question for Massachusetts we have here, which is actually for you, Jenna. Now, and I know this from my own misspent youth, policing is a very distinct function. And as a consequence of that, with its own special challenges, and as a consequence of that, it develops its own culture everywhere you go. That's just true. How has this co-work, how has this landed within the culture of the police department, to the extent that you're able to see? How has that gone down, and are there some challenges which remain? And to tell us a little bit about that, if you, to the extent that you can tell tales out of school or not. What would you have to say about that?
How much time have you got, Alan? It's been a fascinating 10 years. So I was there at the ground level. I was literally there when Best came to us and asked us to start doing this co-response. And it was a severely uphill battle just to get, at every level of the BPD. Officers didn't want to have to babysit clinicians. So for a year, our very first clinician who we ever hired sat in the police station and never got to go anywhere and had to kind of earn. Thankfully, because of him, he is now a police officer. He got the bug. So now he is both a clinician and an officer. But he sat there for a year and had to make him prove himself useful. So, he would and eventually they got to know him and trust him. And through that kind of trailblazing, we have now, it's becoming easier and easier. And now, again, I've talked to some of the most hardline officers who are just still we need our clinicians. So it's definitely, again, it's taken a very long time, but the culture, there's still some really traditional officers who are just resistant. And I think that will always be the case. And I also wanted to point out that, because I know you were talking about PACT, obviously I'm speaking about BPD stuff because that's where I work and that's my house, but in the city of Boston, the interim mayor, who will be around for the next 2 weeks, did ask for other pilot programs to be going on. So we're not only working on improving our co-response, but there's no doubt that you absolutely don't want police at every call. It has to do with mental health. Police don't want to be the line, the net for every call. And so we're also doing a few other pilots. One is where EMS co-responds with BEST or triages and sends calls directly to the BEST hotline so that police aren't involved at all. And then we've also acknowledged that there's a whole sect of people who don't want any uniforms or any authority really whatsoever coming to calls. So we're also doing a community-led design where we just have peers and community-led members who can have their own kind of response along a very similar spectrum to yours. But the important part is it needs to be integrated because things change constantly. So if you have something that the community-led response team gets to and suddenly there's a gun, the reality is sometimes you do need police. And so it's been very interesting, lots of different needs and services, and just lots of we've got some people begging for police, other people saying we want police to have nothing to do with things. And so that culture has also been really challenging. That has also changed a lot over time. It's just how the police are welcomed or not welcomed at things. I'm a liberal working for the police, and it's just been honestly the greatest pleasure of my life doing this work. And but yeah, the police, I'm so proud of how far they have come, but it will never not have challenges to getting this incorporated. And I feel like I'm at a point where I feel like if I were to quit tomorrow, I think I mentioned this when we had a pre-meeting, I feel like co-response would still last, but for the first 8 or 9 years, I think if I had quit and wasn't there pushing, I think it would have just gone down the tubes.
Thanks. That's a very thoughtful response. We have a question from Echo. You may want to unmute yourself.
Sorry, I'm trying to figure out how to do that. Thank you. Thanks, Jenna, for just mentioning that. I actually did work on and then lead our integrated mobile crisis response team, as Johnny said, and there was a time we didn't have police. We really found there were so many calls that really needed that level of safety and containment. And then I think once we were integrated with police, maybe there was a swinging of the pendulum to too many calls with police when maybe it wasn't needed, and we constantly have to reevaluate that. So, and now I lead our assertive community treatment teams that have have recently had a reduction of police officers on our team, and that's been a change management process, as well as our intensive community treatment team that has no police on it. So yeah, I've kind of seen all the different angles, and I think this is this question of, you know, when do we utilize police partners? How do we do that in a good way? And how do we embed police in a way that they can have a trauma-informed approach and a culturally informed approach as we go forward together? That is still something that we grapple with. So yeah, really appreciate you bringing that up, and I would love to see some of the evaluation and the indicators that folks are talking.
Thanks, Echo. Does anybody want to comment before I move to another question?
I just want to mention, obviously, in America and I guess worldwide, it's been a complex couple of years to be working in the criminal justice system, particularly for law enforcement, particularly around issues on race. And there, I will just say that, well, there's been a lot of benefits from having all these relationships, but having this group meeting on the regular while we've been in the midst of all of these navigating, how do we do this and do this well for the sake of all partners and all community members, it has been very useful to have these relationships and trust established so that we can have these really complicated discussions. It is not, we present our work and we all know this, it's really complicated. It has been a particularly complicated year, particularly since George Floyd was murdered. So it's just been significant to have partners at the table to really like be here on a regular basis and to already have those relationships established. And I didn't get to mention that one of the things we are doing is making sure that in the data collection for this project, that we are always making sure that we look at race and gender, and like what's sort of what does our data look like when we're looking at it by race and gender, and not just as the population. That's just one very small slice of the work that is happening around racial equity. But there's a lot I didn't get to in that presentation. We didn't get to.
Well, maybe we can just follow up on that a little bit, because I think there's in both countries, there's a very strong and ongoing conversation about ethnicity, race, mental health, and policing. And here in this country, as I think we mentioned when we are in our pre-chat, of course, you'll be aware, there's been a lot of concern around Indigenous people being shot during wellness checks, other people as well. Obviously, there's all the circumstance around George Floyd and the rise of BLM. And of course, what you're talking about here, what both programs are talking about here is in many ways addressing some of the concerns that the activists would have, right? In that, let's not have a blunt instrument, right? Let's be nuanced in our response to the community. And so maybe starting with our Canadian folks who haven't had a chance to weigh in yet, can you tell us a little bit about how you've thought about that dialogue and worked with advocates in that world to, in designing what you've done, or any interactions you've had around those pieces?
I wonder, Amelia, if you might go first and add some of the intentional planning that's going to happen here in Victoria. And it's great to have Echo here because it's going to be such an interface there, and maybe what you can share about North Shore. And then I'll just round out with a comment about nuance and the bluntness that Alan's just said. Over to you, Amelia.
Yeah, I think it's incredibly important in the community design process to engage activists and people who are social justice minded, even when they are really against systems and system actors. I think one of our first learnings coming into the city of Victoria was that there is kind of strong factions within the community that are very anti-police, anti-government, and really want to be self-sustaining within the community. And creating that process where we're able to create space for the community to have voice and a space for system actors to have voice was really important. And having that role as almost an interloper of holding the two tables accountable to each other was a way for us to really engage that diversity of opinion and of needs, and hopefully build out a service that really kind of responds to the issues that are being raised by activists in a way that doesn't kind of replicate some of the systemic harm or violence that's perpetrated by the systems at present.
I think the only thing I'd add to Amelia's excellent commentary there is, and I was struck by Echo's description there. I think the more we can build out discerning crisis responses, So, you know, I mean, when with Echo's description and ours, like you've actually got quite a robust complement, at least here in the city of Victoria, of a range of responses. So co-police, more mental health specialists, and what we're offering, I think, is a counterpart with the peer side. And what we've noticed in at least the North Shore, linguistically, what we've been able to co-design there is availability of Farsi speaking crisis responders, for example, or you know, finding the right kind of resource and care to respond to undocumented folks, refugees, newcomers, those kinds of populations. And so, you know, the more where we have to build discernment is in dispatch. Like that to us is such an opportunity of how beyond 911 emergency, police, fire, ambulance, I'd like actually to have the ACT team respond, or no, PACT, or, you know, that's a huge conversation that actually has started. I think the more discernment that we can bring into our responses would be so key, and including co-locating, like having someone like on a PACT team sit in a police dispatch room. The more coexistence and the co-alignment, I think, can really, I think, hopefully leverage a reduction or a prevention or a minimization of responses. Within the activist community, there are challenges with co-response, and we've heard this too, because some would argue having police presence on a team, especially when medication compliance is part of the issue, is seen as a coercive quality. You've got someone who's armed and you're having a med drop off. So what does that mean? And so the more that we can do here, I think, in partnership, you know, the more that we can get to whole person, dignifying, supportive responses that mitigate fatal or injurious outcomes. So, you know, it's great to kind of see what we can add to that continuum. Thanks, Alan.
Thanks so much. Donnie, what you are saying just makes so much sense. And Amelia, you too. Like, the other piece that we've really grappled with having police embedded is the impact on the client that we're there to see, but also on the people who surround them. So when we're going into sheltering sites or going into places where a group of people are camping, we have to think about the impact of them seeing an officer, even in plain clothes. It's clear they're an officer, it's always clear. And seeing them come with healthcare services where other people have been traumatized and through institutions, there's that piece as well, right? Mm-hmm. So it's really a complicated interaction.
Mm-hmm.
I just want to echo really quickly what Amelia said about the importance of having people with lived experience at the table. And I wouldn't say like even just the planning table, like all throughout. We have had some really important experiences of having people with sequential intercept mapping. So intentionally, we work very hard to make sure that there are people with lived experience there. And we have had some really important moments where, and this is a high-powered room with the judge and the district attorney and the sheriff, which is corrections in Massachusetts, and other partners, but making sure there are people with lived experience. And we've had some moments where we were talking about involuntary commitment, and the high-powered players were just talking about, well, we just need the section 12 and this, and this, and the emergency department's talking about what they do. And the person with lived experience says, I just want everybody to know that section 12 is really traumatic. Like, so involuntary commitment can be very traumatic for people. So like, can we think about what the opportunities are before that? And knowing that perhaps that might really need to be the opportunity. And people sat back because he'd been sectioned before. And he, we try to do a lot of support for people that are going to be in the room, because it's such a power differential amongst the players in there, frankly. Just the justice system has a big power differential in and of itself. But I just wanted to reiterate that. And I could go on, but I'm not gonna. I'm gonna pause because there's a lot to say about all that.
Well, and then I'll just pipe in and say, Johnny, what you said about the call takers and the dispatch, I feel like that is a black box that it gets far too little attention, and that people in Boston are coming to understand needs so much more training. I mean, it all literally starts with the call taker. And if they're not asking the right questions and getting the right information, it all just goes from there. The entire response starts there. Yeah. Cannot say that enough. And I know that's just kind of a universal challenge everywhere, but it's neat hearing it come from other people's mouths. But yes, that is, can't state it enough.
Well, and I'm sorry, Alan, we see this is what happens when you unleash us. There's, I mean, you look at the RCMP in Saskatchewan, so the F division in Saskatoon, there was a very, very high-profile public incident, no injury, but it just demonstrated the wrong response for the wrong situation at the time. And I would applaud the RCMP out there who quickly moved. They now have psychiatric nurses sitting in the dispatch control room doing active live diversion. And there's good examples in the UK of having, and that isn't rocket science, right? I mean, it's enhancing the intelligence of the response, going forward. So incremental change, I think, can lead to what some are calling the kind of the paradigm shift here, and readdressing the pendulum. Echo's comments were about the pendulum swing, and Jenna and Marissa, your comments were about the pendulum keeps swinging. How do we stop the pendulum swinging and actually build discerning care responses around people? So yeah, we'd be happy to make some introductions there to support that co-location work.
So there are lots of questions which have come in around the whole question. Okay, well, so clearly we're talking about the whole point of this is to apply resources effectively in a sensitive manner to get to get the right outcomes. And so that point of triage, in fact, that point of initial definition of the situation is critical, and we've heard some of that. I'd like to come back to that, but there's a couple other topics which have arisen, and I think we've discussed that a little bit already. So I'm going to move to this other topic, and we have time to come back to that piece around. Maybe I'll ask people to think about, for their last comments, what's the gold standard in terms of how we initially define the situation? Is it on the ground? Is it in a call center with expertise? Like where is that gold standard? But I'll just reserve that question and move to something different, which is outcomes. So it's always tricky, and I say this having tried to push this rock up a hill for many decades of my life now, to find out outcomes within an organization, genuine outcome measures. So what happened when we did this? It's especially tricky when you're doing things that are cross-sectoral, because the outcomes that you're seeking may in fact be measured by somebody else if they're measured at all. And so you also need to have a relationship with that entity to be able to understand your outcomes. If you're doing something which is supposed to have a mental health benefit and you're a police department, how do you find out if that actually worked, right? So I'm accepting this is all tricky. So what kinds of thinking are you doing around outcome measurement for these two programs? And maybe I'll start with our American friends and then move back to Canada.
I guess, can I ask for me and Marisa, do you want outcomes of the sequential intercept mapping or of co-response? Because they're two very different things.
Or both.
Or both.
Oh, well, you tell me. I think I was thinking more of the Boston experience of the
okay.
Yeah.
For sure. I mean, so yes, I mean, you nailed it on the head. I mean, we are having co-responders, but the outcomes are all from Boston Emergency Services team. Every single one of our measures of, it's very hard. We ask the clinicians to collect a lot of data, and we have regular meetings between Boston Medical Center, which Bess is out of, and BPD, because we know we need to have a very strong working relationship where we share data, because they're going to want to know some of our police outcomes, and we're going to want to know a lot of their medical outcomes. And so a lot of MOAs are in place, or MOUs, memoranda of understandings and agreements, but there has to be a degree of trust between these agencies, or else you're not going to be able to get that data. We also have great relationships with a lot of academic partners. We're fortunate here in Boston to have so many different academic institutions. So we have this one particular academic that we've been working with, and so she helps us figure out what data we need to collect, but a lot of it is relying on getting that data from BMC directly from Boston Medical Center. So yes, we rely on that. It's very hard to show. Like, we ask a clinician, do you think an arrest may have been made here? Do you think there is a charge here that could have been, like, a lot of it is so subjective. So it's difficult to show things that don't happen and show diversions from arrests and things like that. And use of force happens relatively infrequently here. So we're not showing some major decrease. It really doesn't happen that much. So it's hard to show. A lot of it is perceptions. A lot of it is interviewing officers or interviewing community members to really just get a sense of procedural justice. So a lot of it is very subjective. Marisa.
I was just going to say that in the last actually like 2 years, one of the things we've been asking communities to do that was different from our first few years was to take a look at what data they have, so that when we do sequential intercept mapping, they have a baseline across a number of different data points, and then they can actually look at, is our work doing anything? Is it impacting anything? That said, we're talking about data that is often not easy to get. So like emergency department data, all of our law enforcement departments very often collect data differently. And it's not easy to access. So we present communities with this list that is in the perfect world. We would be able to see how many people are coming into the emergency department with overdose incidents, how many times law enforcement are on the scene of a mental health crisis. Across every Intercept, we organized by Intercept. But we know that it's going to be complex for communities to gather all of this data. And so we actually do try to support them in that, only because it's wonderful if everybody can come to these workshops and these mapping exercises, and people are, feel very productive at them, but it really only matters if we do something that actually impacts the problem. So it's only been in the last, and I'm saying that like really are bad. I mean, we are data driven in the sense, and we have been in the sense that we are talking to communities about what the evidence-based practices they're using, but how they measure their change is only something that we've really made a push for in the last couple of years, and doing it by race and gender in addition to as a whole. So has been significant. So just want to mention that we have a few levels of evaluation.
Alan, I might just quickly add, we had Sir Norman Lamb with us at the last webinar, and I think, when it comes to indicators, and I know our colleague Juanita in the chats posed this question, I would say, and maybe this is an appropriate way to describe it, but I think there are moral imperative indicators when it comes to these pieces. So the question of, should someone in a mental health crisis meeting particular criteria ever be transported in the back of a police vehicle to an emergency department? So, the United Kingdom have started to legislate stark reductions in the use of police conveyance. Of course, if there's a weapon, violence, there's a need for containment, absolutely granted. But I think the pendulum's way over there in many communities here, where the default is police conveyance. And having sat with many young people, so you've got a 17-year-old who's experienced panic disorder or attack, only thoughts of suicide, and they are conveyed in a police vehicle. What is the impact of that conveyance? Because that kind of experience is arguably one of the most serious things that can happen to someone experiencing a mental health crisis. So looking at getting to zero when it comes to the use of police jail cells in containment of someone in a mental health crisis, the UK government actually really started to get to an ambition of zero, as we heard Norman say. So I think there are some of those indicators that I think I would call imperative indicators, where we really are ensuring the right kind of response, a dignifying response when it comes to care. Because I think there's far too many occasions when there's no risk of harm, no weapon present, suicide ideation, right? Or what have you, and handcuffs conveyance happens, or sitting inside the hospital, so it's interesting to see how the UK government have tackled some of those indicators in their push for change.
I wonder if at this point I could actually bring in somebody who's been making a great contribution in the chat, who unfortunately I can only identify by their chat name is PDR Fincham, but I just noted that they are an inspector with. So I wonder if Inspector Fincham, if you'd like to just make some of the points that you were making in the chat in the discussion, because I think they're great.
No, thanks for the invite to speak. It's great to hear the discussion. There's a lot of partnerships on the screen here that I haven't had a chance to meet. This is my second trip back to the mental health unit with the Vancouver Police Department. So Johnny, I've heard great things about you, and I'm looking forward to meeting with you and chatting, as well as Jenna, who's very engaged with our partnership program. So it's nice to see the team here. Great discussion. It's, we've had these challenges for many, many years. How do we eliminate police from that equation? How do we provide a better community response? And we have a number of programs developed in that regard. And one of my comments about the mobile community response teams, whether you're following a Cahoots model or a Memphis model, or what's happening in North Vancouver, whether it's community-based or whether it's medic clinician led, or whether it's police clinician led, which is the model we have in Vancouver with the mental health nurse. We find now our biggest challenge in policing is to look at the focus of our attention, and that's on the moderate to severe cases. And like my comment off to the side there was, we have a lot of embedded support in Vancouver on the community side. Whether it's Pender Clinic or Heatley Clinic, a lot of places working in the downtown east side, which is a challenging environment, that we're focusing our energy on the moderate to severe severe cases and cases of unknown risk where we're deploying resources into an environment where we simply don't know what's going to happen at the end of the day. Not to say that we're dealing with clients that are inherently riskier. They're living in an environment where they might be living next door to a predatory drug dealer, or they might come across a violent event when they're down there serving the community. So those are some of the challenges we face. I think we're all in agreement. Limiting police resources into those environments is the key to success. Unfortunately, we do have a number of clients that simply we do need the police support to keep our clinicians safe, which is our ultimate goal. As well as client safety. We believe that we're better off serving the community with a very well-trained base of police officers, in addition to all of our officers being trained in crisis intervention response. But our goal is to keep the clients safe by providing a specialized police resource, as well as keeping our clinicians safe to make sure that they can engage in the community.
Thank you. Excellent points. And especially the last point around training, which is, without which none of these good things can happen without effective training. I wonder if in some of the time we have remaining, I could just turn our attention to the question of the law and ask our presenters the following question. A, have any laws had to change to enable you to do what you're currently doing? And another question, ought there to be some laws which change to allow you to be more effective in what you're doing in your own jurisdiction? And maybe I don't know who wants to go first. I'll just throw it open. Whoever wants to jump into that viper's den of issues. But
I'll go, because I was going to bring it up anyway, but it aligns with this question. Marisa mentioned Section 12s. There is a very big debate going on about Section 12s in the city of Boston right now, and it does relate to the law. So I just figured I'd bring that up. So Section 12s allow someone to be taken involuntarily to an emergency department where they have to have a psych evaluation. And then if a psychiatric doctor finds it necessary, they can be held involuntarily for up to 3 days. These can be, only certain people can write these Section 12s, including social workers, doctors, and police. And historically, doctors would just fax these over to the police would just get it and go find them and use whatever force necessary, because it's been deemed necessary by a doctor. This person is at risk of harm to self or others. They cannot stay in the community. So police would use force if necessary and take them to emergency departments, or help them get into an ambulance and take into, usually the EMS would do the transports, and EMS would do it in an ambulance. But a new rule has come out because of a state law. A state law, as a result of George Floyd, it's called post legislation, came out in the state where now, I'm pretty sure this was not the case before, but now officers can be criminally charged if they use excessive force. And so a lot of officers, Section 12 is, that situation has such potential for force to be used, because of course the whole point is we know it's not voluntary, and bad things can happen when serving Section 12s. And so this new rule has come out that emphasizes de-escalation, especially if it's suicide. If someone's in a room just threatening to harm themselves and that's the only risk, then should an officer barge down the door and endanger themselves and others around this person, rather than backing down. But now that de-escalation is kind of given as an option, a lot of healthcare providers are getting very upset that there's now this gap of service, because if an officer deems that there's no exigent service in this moment, exigent need in this moment, then they're just going to back down and leave the person in the community. And the service provider is like, but now there's a gap in service. We've already deemed this person as being high risk to self or others, and we've told you need to take them in. But as Johnny said, why would someone being suicidal want to be handcuffed? And is that the right thing to do? And if something goes wrong, it's the officers who are ultimately liable. I think that psychiatrist who wrote the Section 12 might be able to be civilly liable, but officers can now be criminally charged if they've used excessive force. So the big thing is this, what about the law? The law has not taken into account who does what and who's liable for what. And it's this big discussion going on right now. And yes, ultimately this law where it's not clear how much force can and should be used when a Section 12 is written. Is it okay for a psychiatric doctor to tell an officer when to use force? Because it's officers who know when to use force. They're the ones who in the moment make that determination. And how are we letting medical doctors make that determination? But they think they should be. We have told you this person has to come in. You have to take them in. So this is a huge, huge debate going on right now in Boston, but it's a state law. And ultimately this debate is going on because the law has holes in it. And so, yes, it's a major issue going on right now. And the law is going to have to change, I think, in some way or shape or form. Hopefully that's a relevant answer. I don't know.
Oh, very. Other thoughts from our presenters on this topic?
We've been kind of public on the record, Alan, here in BC of the necessity of taking a close look at the Mental Health Act, which was drafted in the 60s, so the last century, and was last modified in the last century. Just given the, I think we applaud, the government's leadership to take a look at this Police Act, which is fantastic. There's a great opportunity, I think, to take a look at the Mental Health Act, and I would say that's just one space where, there could be consideration of more explicit language or adjustments to language around where people can be taken for care. Who are the conveying forces there? Here in and around complexity, we haven't really taken a close look at extended leave here. So extended leave is basically you're on condition in community. You can be recalled at any point back into detention. Some folks don't always know they're on extended leave, and police are often the conveyor there of our extended leave provisions in community. And so, we need to take a look at, are people being detained for the shortest possible of times because a curtailment of liberty is pretty serious, right? And so are we detaining people are we doing it in the least intrusive way possible? I think Jenna's commentary there about use of force is a live conversation here too. There's a bit of a different dynamic there as well, but the same rules apply. Like police ultimately decide what force is used at the point of detention. So that I think the Mental Health Act, and I think there is appetite amongst there's great leadership by Health Justice, the Community Legal Assistance Society, in encouraging decision makers, legislators, and policymakers to do the right thing and take a close look. Is the Mental Health Act fit for purpose when it comes to arguably where mental health care is at on November the 4th, 2021, when it comes to provisioning of care? Because as Jenna said, we've heard it from folks with lived experience too. Unless you've been detained, restrained, and held, that experience, I think, is very, very important to listen closely to. Some people are, I think, quite averse to tinkering with that act because they worry about, I think sometimes the assertion is, that there'd be bedlam in the streets when actually, no, I think we have to see, is this act in alignment with, human rights provisions and those kinds of, those pieces. And I think modifications to that act would better clarify for our partners in policing, where their duty of care and where their response lies. And I think our colleague Inspector Fincham has his hand up too, Alan.
And he has the floor. Thank you, Johnny.
Yeah, it's the use of force, sort of, that's my realm. So kind of a unique position I'm in. So I'm a critical incident commander with the Vancouver Police Department, where my side job is deploying police resources in response to critical incidents throughout the city. This might be a barricaded individual who finds himself in a mental health crisis or a variety of events. We always have had the potential for our officers to be subject to investigation, charged criminally for a case of excessive force. In Vancouver, we do approximately 4,500 apprehensions a year. So this is a mix of Section 28 unique apprehensions, which is about 2,800 a year, and then another 1,700 forms. So whether it's a justice or whether it's a doctor or whether it's a recall into hospital where a person's needed to be taken into care, it's about 4,500 times a year that our officers are actually engaging with clients in the community to take them to a setting within the BC system under the BC Mental Health Act to deliver them to a physician. It's very rare when you look at 4,500 cases statistically to have events where we are actually causing harm or excessive harm to an individual in those cases. And all those cases for the most part are documented. Unfortunately for us, we're all subject to what we see on the news, whether it's something that happens in British Columbia or Canada or North America. We're all subject to what we see on television. But it is important to note when we do the analysis, it's very few cases where actually there are incidents where somebody is harmed in these events. And we follow a standard of reasonableness, whether the force used by a police officer in any event was reasonable given the nature of that event. And there's a significant review in any of these cases that take place. So the use of force in policing isn't handled or isn't taken lightly. It's a very serious thing. We are just now releasing our new handcuffing policy in regards to a number of incidents that have taken place in Vancouver to, not restrict, but to provide further clarification on whether it's appropriate to handcuff an individual, whether that's an apprehension, which is, completely different than an arrest in a criminal offense. And again, we do take events that when we're dealing with a mental health primary event, a lot more sensitively than we would a criminal case. We're very sensitive to stigma in transportation of clients, in the handcuffing, whether it's necessary or not. And a lot of the times we say it comes down to safety again, safety of the client, that we don't want them to do something that's going to result in them themselves being harmed. So that sort of shed some light on the use of force question.
Well, thank you very much. And so now, being conscious of the time, I'm going to offer each of our presenters 20 seconds to tell us what someone should keep in mind if they are embarking on doing this kind of cross-sectoral work, particularly around crisis intervention. I'll start with you, Johnny, because I know how quick you are on your feet.
I would say my 20 seconds would be, and I think that the comments has been made, is collaboration is critical with all partners. I think our success in making change and continuing those improvements, it's great to hear from the inspector some of those changes. It really is about sessions and collaborative dialogues like this, Alan.
Thank you. Jenna.
I guess building on that, I would say finding the right people as well. I think part of why the sequential intercept mapping and the co-responder subcommittee have been so successful is that we found the people who care about this topic and who can affect change and also take that change up the ladder in their organizations. So I think, again, you might have more bureaucracy at the very top, but I feel like finding those people who are really involved and are interested can go really a long way.
Thank you. Amelia.
I would say just building consensus around what the issue is that necessitates collaboration, because all the different stakeholders come with different perspectives and different mandates. So really getting clarity around what the issue is and then centering people who are most impacted by it in the solutions moving forward is most important.
Thank you. And final word to you, Marisa.
You can tell we are all cut from the same cloth. This is basically just another version of what everyone has said, but I would center also the importance of coalitions, like of sustainable coalitions. This work takes a long time. It's complicated. We need to build trust and have a space to have these conversations, or else we all get stuck in our silos. So coalitions.
Isn't it just? Well, thank you to all of our presenters for what I think was a really engaging and fascinating discussion. I'm sorry it has to end, frankly, but it does. And I will just note for our viewers that this is the last of these for this calendar year. We are now starting to move towards obviously planning the physical in-person event, which we had planned to do before COVID hit us. But we reserve the right to do at least another webinar or two in the new year, and we'll advise you as to the schedule of that going forward. Thanks to everybody for your participation and for the presenters for their hard work, and very much enjoyed today, and we'll see you next time.